All right, everybody. I'm just going to do a quick welcome and go over how to get your credits and how to do the quiz, and then I'll turn the time over to Kara to introduce our speakers. I'd like to welcome everyone to the webinar today. Based on new requirements from the MDCB, all webinar participants have to take the post-webinar quiz in order to receive credit. This does make it easier for those watching in groups. You no longer have to report who is in the group. But please take time after the webinar to take the post quiz. It will be available along with the recording until September 30th. Can everyone hear me? Had a couple things that you couldn't hear me. Yes, okay. If you can't hear anything, try to unmute your speakers. Anyway, the webinar quizzes and the recordings for each of the webinars this week will be posted. The main link is right here on the homepage. You can pretty much use any of these links to get there. They all go to the same place. If you click here, after this webinar is over, this link right here will turn into the recording, and the quiz is already posted. So you're welcome to pull up the quiz now, take a look at it, follow along. I don't know if it'll time out, so I wouldn't recommend just filling it in and going throughout the webinar. You might want to copy and paste and just record your answers. I don't want anyone to take the quiz and then have a timeout and have to do it again. But the quiz is ready to go. Just click there, log in, and you can take the quiz. Non-members as well. If you haven't done it already, non-members are welcome to get credit. This is open to anybody. You just got to go here under membership and then create a non-member account, go through the process, and you will have access to the quiz as well. So the quizzes, the lectures are all open to anyone who can earn MDCB credit or ART credit through September 30th. If you have any questions about the webinars this week, about the education process, what AAMD has going on, regional meetings, annual meetings, feel free to write those during the presentation and I can answer them. Mark and Freddie will be taking questions at the end of the presentation, but if you do have something that's easy for them to answer, Freddie will be answering questions on the fly throughout the webinar. So at this point, I will turn the time over to Kara to introduce our speakers on the topic.
Thank you, Spencer. Hello, everyone. My name is Kara Sullivan, your current AMD Secretary. On behalf of the AMD Board of Directors, we welcome you to the first National Medical Dosimetrist Day webinar. Today's webinar is Adaptive Therapy and Deformable Registration, sponsored by RaySearch. Our first speaker is Mark Mullen. Mark is the President and CEO of RaySearch Americas. He has over 20 years' experience in radiation oncology. Prior to his current position at RaySearch, Mark was VP of Marketing and Product Development for Civco Medical Solutions. Mark received his board certification in dosimetry in 1994, and he wants all of you to know that he is not just a business guy. Freddie Cardell will be assisting Mark with the presentation today. The AMD would like to thank RaySearch and Mark for today's presentation, and we hope you enjoy the webinar. I will now turn the microphone over to Mark.
Okay, thanks. Kara, can everyone hear me? Okay, I see some yeses. Wonderful. Thanks so much. Okay, yeah, so Kara, I do appreciate the introduction, and I did ask Kara to make sure that everyone is aware that I am a medical dosimetrist. Sometimes when people hear that a president or some business guy is going to get up and talk about something, it becomes an advertisement, but I wanted it to be clear that the presentation today is going to be about a technology and about something that's really important, I think, to all dosimetrists as well as to physicians and everyone else. Freddie Cardell is the Director of Customer Service, and he's supporting me today and will also assist with answering questions towards the end. So without further ado, we're just going to get started. And the disclosures, as we always begin with, obviously I'm a RaySearch employee, and the images that I use in this presentation are primarily from RayStation, and that's of course because I have access to the product and I can take example images and that sort of thing. But most of the technologies and most of the features that we're going to talk about today are available in one form or another in several different products, and we'll talk about that very briefly as well. So the agenda, we're going to talk about why deformable registration, in particular, why is now a very good time. We're going to talk about use cases, or most useful cases that we've come across in the field to sort of understand why people do deformable registration and how they can use it, and sort of how they phase it into their departments. What are the implementation challenges, and why has it taken so long for this to really get to mainstream? Technical approaches and some of the ways that one can or should go about deformable registration and adaptive therapy. Key functionality, and this I hope will be an important piece for you. It's where we talk about the different technologies that you need while you're trying to get this done. And so, you know, whether you take notes or come to our website to see some of these things, I think it's useful, because even as you look at other products, it's a really good way to say, does this product have what I need? We'll go into examples. I think I have 2 use cases that we'll actually bring up on the screen and look at it from beginning to end. And what does the near future look like for deformable registration and adaptive therapy? All right, so why do we need deformable image registration in the first place? And historically, it was assumed that everything stayed the same, right? You know, when we had certain field sizes and we were treating, whether it's a prostate or a lung, whatever it is, you know, you would make shifts based on port films, but, you know, and SSDs. But the reality is that we're making a lot of assumptions, and in the case of things like lung, I think that the failures that we've seen over time were because this very thing is not true, right? Things are not the same. And then came along image-guided radiation therapy, which, yes, it's a buzzword, but really what it represented was better port films. It represented Cbct. It represented surface image analysis, all kinds of things that people used. And we started to realize that patients were moving. We noticed how much internal organs move, right? We've all seen the videos of organs moving around within the patient, whether it's Cbct or some other imaging modality. Don't worry, that's not in this presentation. I figure you've seen it enough. And then we could not ignore that we were missing targets on a regular basis, because now we were looking at it, right? And modalities such as MR, PET-CT, Cbct really became commonplace. The LINAC vendors started including them on the systems, or the radiation oncology suites started to include these alternate imaging modalities as a matter of course. So what is adaptive treatment planning? So adaptive treatment planning is when you have a plan and you say, you know what, it's not working, I'm going to go to plan B. So just real briefly, what changes from day to day? You know, you guys all know this. Breathing, mushy structures, gas or liquid filled structures, GTV changes and CTV changes due to time or new information that the physician gets, or impact and effect of the radiation treatment itself. And then of course patient weight changes, most notable in head and neck cases where, as you know, the patients have problems with morbidity and may have a problem eating, and of course the impact from chemotherapy, that there's quite a bit of patient weight change. So IGRT and adaptive treatments attempt to counteract the motion with daily imaging and repositioning, right? So you get whether it's a Cbct or whether it's a port film, whatever it is, and you try and move the patient to the place where they need to be for that day. Adaptive treatments, of course, want to adapt the plan and dose distribution to correct for the changes that occur. So essentially, I'll show another slide where we talk about the fact that what adaptive treatments are really doing is they're compensating for the failure of IGRT to really resolve the problem. And of course, as you're looking at all of this data, such as this image guidance, the real benefit here for all of us is that we're able to build more advanced models of patient dynamics. And we'll talk a little bit about that when we actually look at the techniques for deformable registration and how to look at the images. So what are the most common use cases? And hopefully this is where it starts to connect this technology with what you need or could use within your department. The first is retreatment or treatment to a nearby body site. Patient comes back for treatment, they were treated at another facility, they were treated in a region that maybe last year, and now there's metastases where you need to treat somewhere nearby. So I think maybe some of us, not all of us, remember the days of, you know, using overhead projectors and projecting CT scans and trying to do fusions and sort of adding together dose and considering what was nearby. But this is something I think we're all faced with in day-to-day clinic, and this is one use case. Another fairly common one is significant physical change that suggests that a new plan is needed. And you know the situation here. You have a patient under treatment, the physician or the nurse says, this patient's lost 20 pounds, or the therapists say that they're fitting very loosely, the mask is fitting loosely, and when that happens, you start to realize that dosimetrically there could be an impact, and I do have a good example of showing that. Another use case is where we move towards regular imaging, Cbct, and we want to track the dose on a consistent basis, and this would be necessary, for example, with dose escalation, significant organs at risk. SBRT is another one I probably should have listed there, where we want to look at the dose every single fraction or every other fraction, and then to be able to track that and decide what to do about it as the treatments are going on. Another one is where we do expert data mapping from Atlas data sets. There are products out there that have used deformable registration to accomplish this. So maybe the old ICO products, I think Anatomy has something out there. You get the idea where basically I want to go from one data set to another and to use that information to the benefit of the current plan. And the last use case I have here is simple 4D data set where I have multiple phases, whether or not I want to do gating, where I want to take a look at, for example, a lung with 4D and to assess how I should treat that patient. So these are the most common use cases, and if people have others, it would be really interesting to hear those because these are pretty much the ones that, that have come up in our interactions with customers. So what are the levels of action, right? So there's things that you can do based on the information that you have. One is with simple IGRT, I can observe and correct, right? This all makes sense. I can reposition the patient at the time of treatment, and I put in the little punchline there, I've got robotics, because as many of us know, the corrections patients don't just necessarily shift incorrectly in simple directions. There can be rotations, there could be yaw, pitch, roll, all of these things that make robotic couches very helpful. Then there's dose tracking, which is a method of quantitative observation. We compute fraction dose based on the daily imaging. So whether it's cone beam CT, whatever it is, sometimes you have CT on rails if you're lucky enough, but it's essentially where I'm looking at the dose on a daily basis and I'm going to do something with that. And you can accumulate that dose via deformable registration, and I'll show that going forward in this presentation. And it's the evaluation of that accumulated dose that helps us to assess whether or not the treatment plan needs to be revised, and I can use DVHs, all sorts of visual information, statistics. We'll look at that as well. Of course, the third level, when the dose tracking has indicated or the IGRT has indicated that we've got a problem, then of course you need to replan. And we do this now, right? But essentially, adaptive plan, as I mentioned before, is the acting on the failure of image-guided radiation therapy to correct, and this accounts for patient-specific variations. There can be systematic changes, such as tumor shrinkage, but it could be that something is moving in a particular direction. Whatever it is systematic that happens that you may want to correct for. And of course, we're compensating for undesired dose accumulation. So if I have more dose to an organ at risk, something along those lines, then I may choose to replan the patient just for that reason alone. All right, so here's a question. Why doesn't everyone do it? The technology really has been around for a long time, right? I mean, if we, in a minute, I'll show you the different products out there that do it. But certainly, if people haven't been doing it, they've been talking about it, right? There's at every single meeting you've ever gone to, there's lots of presentations. Well, the reason is that change is not easy, and it's one of my favorite sayings about, well, change in general, but in this case it's particularly true, that it's a very short trip from riding the waves of change to being torn apart by the jaws of defeat. And the way that you can be defeated in adaptive radiation therapy is there's a multitude of ways. For example, there could be more work or effort that's needed than your department can keep up with. There are all kinds of questions about, do I trust dose accumulation such that I'm comfortable retreating in a certain area, especially where there's organs at risk? It's not a simple question, and everyone within the department physician, physicist, therapist, dosimetrists, everyone have to be completely involved in the process to say, you know, this is the way that we're going to do things. Now, again, there are ways to introduce this technology without going directly to adaptive therapy on every single patient. So for the example of retreatment of patients, or where I've got a case where patients change during treatment, these are somewhat simple scenarios that we can implement now and then not have to go with the full scope of things that are available out there. But there's other reasons why. It's not just about fear of change. The technology is not trivial, right? It's not easy to do right or to offer all of the needed options. So if I give you a tool set that allows you to do deformable registration and adaptive therapy, this may or may not really support your efforts. And you know, you want to implement this technology the way you want it, not the way I want it, meaning me as the vendor. There are still several discussions and arguments that exist on the deformation of dose. We've seen points and counterpoints in the APM and the Red Journal, for example. There's lots of papers about how to do it. So your department, your physicists, everyone needs to buy into what this means. This is not APM's fault because this is a very complicated question, but you know, TG132 is close to being released, but it's not out quite yet. And this is the task group that will publish a wonderful document that's supposedly going to help folks to understand the best way to move forward with these technologies, with recommendations, how to perform QA, how to do a quantitative analysis, things like that. So I think a lot of people are waiting for that. Research has been slow and inconclusive, primarily because there are so many use cases, right? So as I mentioned before, maybe it's a great thing to do right now as my patient is going to be retreated or they've changed shape, but should we do Cbct every single day? Lots of different use cases. This is an interesting issue which I won't go too much into, but you know, as you probably know, there are treatment planning systems and there are standalone products, and the question sort of comes up, do I really want to do some of this work in one product and then send the data over to my treatment planning system? Do I want to go back and forth? As the technology becomes more ubiquitous and everyone has it, then of course it becomes a little bit easier to implement from a workflow perspective. QA, whether it's physical or synthetic phantoms, did not exist, and or it was not clear how to accept those products and perform ongoing quality control. And this is a big deal, right? Just because I implement a product, what's the QA that I need to go through to accept it? What do I do on a regular basis? There's many different things, many questions that the department will have about how to trust this going forward. It is, and I put was with a question mark, time-consuming, both computationally and professionally, to perform the deformable registration and to execute adaptive plans. Someone's got to do it. That someone is us, the dosimetrists, right? But tools have to be developed to make it a little bit easier and perhaps to automate a lot of this. And of course, just the computers, as they get faster, make it a little bit easier to implement as well. Lack of clear reimbursement. This is, of course, true primarily in the United States. There's more work that needs to be done, right? We all know we're faced with this question every day, but you know, perhaps for replanning, it does offer the DVH information and image information that can help validate the need for adaptive plans. So that's part of the story. It's not the whole story, but it's part of it. The other point here, and this I think is the most important point, is that we don't have academic direction yet as to when a plan should be adapted. One of the biggest dangers of any technology is using it for the sake of using it and not knowing when you're overdoing it. A great example, which I'll have a nice image of a DVH later, is if I look at 4 fractions in and my PTV is dropping off by 5 or 6%, does that mean that I need to do a new plan? And different people have different answers, and my first answer would be no, because that's what a PTV is designed for, is to absorb errors in patient positioning. But it really does raise the question, what do I look for? Do I look for organs at risk? Do I look for the dose coverage? Do I look for whether or not the error is systematic? Do I extrapolate out to see what the impact is going to be for 40 fractions, or what if the total number of fractions are? This is probably one of the biggest things, and this is what we're going to count on the big academic centers to help us out to help figure out. So what are the products for registration and adaptive therapy? On the left, you have these quote-unquote standalone products that do a combination of deformation but also do some good work on the PAC side. And then on the right, you have the TPS systems. And of course, there are varying degrees of implementation. Each vendor goes about it a little bit differently. And on the left, I do make one note, which I'll revisit, which is that may not be good for dose accumulation in certain directions. For example, with a daily Cbct, where you don't have dose calculation on the Cbct, it's not rational to do deformations with that image set because obviously the physics have actually changed on that cone beam CT. We'll take a look at a real example for that in a minute. And over time, what we're going to see is that some of these standalones will become incorporated into treatment planning systems, sort of like we saw with Velocity. So we're going to talk a little bit about deformable registration in RayStation. We do a hybrid registration, which uses the anatomical information within the patient. So our little nickname there is Anaconda for anatomical constraints and deformable adaptation. Basically what happens is that we do use anatomical information, whether it's ROIs, POIs, and as you'll see, actual anatomy as well. And that not every vendor does that. That's really a decision that you have to make as to whether or not basic physical information is sufficient. So, just the grayscale from a CT, for example. We don't believe that that's sufficient. We really want anatomical information in there. We'll talk about how we do that as well. We found out that to do this right, that you really need to be on the GPU. Even with dual Xeon CPUs, it really makes a lot more sense to do the deformable image registration on GPUs. It can increase the speed by a factor of 20, and as you go towards online adaptive therapy, which means rather than just doing the deformable registration and calculations offline and then sort of coming up with a new plan the next day for that patient or 2 days later, it's really good to have a GPU so that you can potentially move towards doing this in real time. The supported image modalities are CT, Cbct, and MR, and of course PET-CT goes with that, and there's many different ways that you can implement that. This extends out the idea of the anatomical usage through this biomechanical registration called Morpheus. We licensed that from Princess Margaret, and it's been implemented in the latest RayStation. And essentially what it does is it uses information from the patient, anatomical information, to help control the registrations, and I'll show you a sample of why that's a good thing a little bit later. There are some differences. We do deal with boundary conditions from controlling structures, and this is a finite element modeling solution, and it is applicable to any image modality. And I do have one more slide, I believe, about Morpheus with a couple more details. Okay, so overall, we combine image information with anatomical information to give you a good result. And it's a nonlinear optimization problem. We do use our own algorithms to do this. And I'm going to show you very simply the things that we sort of do in English. There is a slide after this with some math, and I do that so you can earn your credit for although it's not in the quiz. But I'm going to explain the 4 things that we look at when we're doing this deformation. The first is an image similarity term. So this is really pretty common where you do this reference and deformed target analysis, and you want to sort of analyze what the difference is between the images. The next is, and I've got a graphic display 2 slides down the road here, but where you take a look at the grid and you want to make sure, this deformable grid, and you want to make sure that as you go from one data set to the next that you're not doing something that's virtually impossible. So the way that these elements are set up, you don't want them to be inverted, you don't want to get weird images that sort of come out of it. The third thing is shape-based regularization, which is where if you have a lung, and I'll show you an image of this later, you don't want the lung to change into something that just doesn't make any sense. And of course that depends on things like model-based segmentation or other models that you may have within the treatment planning system. So you want to make sure that these shapes change appropriately. The last item is something that we use as part of the anatomical constraints, and it's a penalty when you use controlling structures. And I'll also have an example of this where, you know, if I want to help the system to understand how the deformation should go, I should be able to put in these ROIs that I say, okay, this is the ROI in this data set, this is the ROI in that data set, and then what that does is that helps the treatment planning system understand overall the three-dimensional mapping that's happening so that you don't get a ridiculous result. And I'll show that. So these are the four, if I had to boil it down into sort of the four key elements that go into this in English, this is what really goes into it. And this is, of course, we can share more information along in terms of the mathematics, but they're not trivial, where I take reference and deform image sets, and we can calculate what's going on. And this is just basically one component of what's going on, as I showed you before in the image similarity. So as you can imagine, the mathematics that goes into this is pretty complex, and as I mentioned at the beginning of the presentation, this is one of the reasons that not everyone has done this, because there's lots of different ways that you can go about this mathematically, and you know, how do you test and look at certain standards to make sure that you're doing the right thing. This is what I was talking about in terms of grid regularization, and you're not supposed to have inverted elements, which obviously is physically not possible, and so it's things like this that really they'll make the system take time in doing what it's doing because of that complex math and the checking that goes on. That's all I have to say from a math perspective, so you guys take it easy now. All right, now that being said though, you know, a lung will never become a cord. Okay, and that's because you are, as I mentioned before, you're using the rules that go into the three-dimensional definition of these structures, usually represented in mesh format like you see here, and that's how the system understands it. So the days of the contours, the individual contours per slice, are kind of over if you want to have a lot of information that the system can incorporate and use. What we do is, of course, if a physician wants to draw by contour, slice by slice, they can certainly do that, and then what happens is that within our system, those slices are sort of put together and a representation in mesh format is created. And conversely, if I have this wonderful mesh representation and I want to send this to another treatment planning system or to a PACS or whatever it is, then this will be converted into something that those systems can understand and DICOM-RT can represent. Okay, I mentioned controlling structures before, and I'm just going to toggle back and forth here. You can see that here's probably the fused view, here's a CT view, here's an MR view, and just in this particular case, the contrast is not so hot, and so what happens is that when the deformation is done, the bladder is not correctly managed, and so what the user has done in this case, they said, okay, here's the bladder, and here's the bladder. And then what happens is that the result that you get is just going to be a better deformation overall three-dimensionally, because now it understands, hey, this bladder dropped down here. It's not like what I thought before. So, you know, in reality, deformable registration is not a perfect science, and as a dosimetrist, as a physician, there are going to be structures that ideally you want to identify. This is why RaySearch believes that the anatomical constraints are so important and they're a major part of the whole deformable registration experience. Now, that of course does mean that there's some more effort that's involved, and that's why automation really becomes important. Okay, a little bit more information on Morpheus. We do use a combination of MBS with using mesh information on these structures. We can handle the intersections between the structures. It's very important that the material properties for each region of interest are part of the library. And this helps to make sliding interfaces possible. So sliding interfaces, what those are essentially is for example, pleural spaces between the lung and the chest wall. There's things that are going on between the diaphragm, the liver, and the lung. There's a lot of different places where a biomechanical knowledge of what's happening is going to help to make a better representation in deformable registration. So we're moving, I think everyone will, move away from pure image-based deformable registration, which can be questionable, right? Consider if you have your patient with frog legs and you go to another image data set where they're not, and now you do the deformable registration, and all funny things are going to happen with the bones because the system is going to do whatever it felt it needed to do to complete the registration. And really what you want is for the systems to be much more intelligent about how it handles the patient's body. This is just some side information in that we do differ a little bit from what the folks at Princess Margaret originally implemented. We have these boundary conditions that have been modified, and we added some third-party components with some mathematics solvers and representation of the meshes into our software. There is a reference here. Christy Brock published a paper. This is the 2005 paper, I think, where it all started, but there are several papers that have been about Morpheus, so if you want to take a look at that, you certainly can. This gives a little bit more information about why we do this, and if you have a deformation of 2 lung data sets without sliding windows, you look at this, I'm not sliding interfaces. If you take a look at this, you say, well, it looks pretty good. I'm looking at my diaphragm, I'm looking at the bones. But then if you zoom in a little bit and you get closer to the ribs, you can see that the ribs aren't quite right. Which may or may not be a big deal, but it's certainly representative. And then when you take a look at this with the Morpheus algorithm involved, that you get a better fit on all of the bones, not just maybe some in the arms or within the lung itself. So it really can make a difference. And I don't have other examples here, but you can imagine with liver and other cases like that with our sliding surfaces why Morpheus has been implemented. Okay, so now we're going to shift gears a little bit here, and we're going to talk about the key functionality that you should look for in any treatment planning system or any system in general to help you accomplish a deformable registration and adaptive plan. The first is the ability to create a deformation between any 2 data sets, okay? So essentially if I select a reference image set here and I have all of my other data sets, whether these are CBCTs or obviously this example is with a CBCT, a daily CBCT, but it could be a head and neck with 3 or 4 different things, pre-op, post-op, new data set, old data set, whatever you have. I do want to be able to do this, and I want to be able to implement these controlling ROIs or points of interest as well, and or focus particular on some ROIs. So you want to have flexibility in the system as you do your deformation. Now the other part here is, okay, great, I can do deformation between data sets, but after my physician has done all of the contouring on my planning data set, how do I get this stuff to other data sets that come in? In this particular case, this is a 4D lung, and this is a really good example of where I want a simple way to get my structures from the maybe phase 1, and I could choose which of the structures I want to move over, and I can send them all over to the multiple phases that exist. And it's really important to note here, although this is not the screen where the option is listed, but there's a location where you could say, you know what, after you copy these over, don't just copy it over based on the registration, but also go ahead and try a model-based segmentation upon copy of all the structures at once to see if the system can automatically adjust the structures to what it sees on the CBCT. This is, of course, much better if you have a CBCT with good quality. Another thing that you want to be able to do is to map the regions of interest from a data set to another data set. So once I have a deformable registration, which I've created, I can tell the system, go ahead and take that ROI and map it across the deformable map. And this is, by the way, this is a great way to do quality assurance, right? Especially if there's a structure that you know, like maybe the femoral head or something like that, where you know what it looks like, you know that it's a solid object. And I say, go ahead and map that across. And it's very interesting to look at how those things map to say, is my deformable image registration, sometimes known as a DVF as well, does that map look correct when I map those structures across? Okay. Another thing that you want is the ability to handle multiple data sets. In this particular case, a 4D data set, and you want to be able to group them. So I can have multiple 4D data sets. I want to be able to group them. I want to be able to create a MIP from those. I also want to be able to create ITVs from those multiple phases in the different views, and I want to view those in a cine loop. Okay, this is the screen. I don't know how well you could see it, but this is where I can create an ITV by selecting the structures, giving it a margin, and saying, okay, let's take that GTV and let's expand it based on everything that I see from the multiple phases. So that's how you can do it automatically. The next slide is a short video, which may look a little choppy depending on your connection, but just to show that in the treatment planning system or the system that's managing things, you want to be able to select and to import multiple data sets, whether they're CBCTs, whether they're just multiple diagnostics, whatever it is, you want to be able to easily bring them in. You want to be able to switch between them easily, and you want to be able to put them in a cine, the way that you see here. And of course, during the cine, you also want to be able to view it in different perspectives, different orientations. Okay, so it's very important that, you know, when you start talking about these using 10, 15, 30 data sets, you need to have a really flexible way to manage your images. Hopefully that video worked for you guys. Okay, and now we move towards some evaluation tools. This is, of course, RayStation, and some of these things that I'll show you will be fairly standard, but you want to be able to select which ROIs you're going to look at. And by the way, it's also really good to have one representations for bladder or for femoral heads and so forth, so you don't have to deal with femoral head in every image set, a femoral head for your CT and each CBCT. You want those to be simple to manipulate, so having one femoral head and that simply exists on each one of these data sets, that's really an important thing, so it simplifies your view. But you want to be able to change the way that you view them, side by side, image comparisons, overlays, etc. And another really important thing that people overlook is that when you're doing deformable registration, you may have different registrations that you test. So maybe I want to do one with Morpheus. Maybe I want to do one where I did a rigid registration first. Maybe I didn't want to do a rigid registration first. There's many different ways that you can select which registration you're going to look at. And this is I think the next slide is a pretty conventional view where you have an overlay on the left of the deformed data showing the fusion, whereas on the right it's more of a rigid overlay, and then you can kind of see the differences between the data sets. So this one, if you have any systems right now that do something similar, this should be pretty common, pretty familiar. In this case, you can look at the planning CT on the left with the extent of deformation that the CBCT had to be manipulated. Okay, and so on the left with the color scale, which I can identify, I could see that more deformation happened here, some more in the corners, that kind of thing. And this is the reconstruction of the CBCT after the deformation has been applied. That's another view. Once you do deformations, it's really important to be able to, either before or after deformations, to look at point mapping between the data sets. So hard to read, but it says point evaluation there, and I can put my mouse anywhere that I want, and I can see how it shows up on the other data set, and this is a nice way to look between. You also want to be able to view the deformable map, and not all systems allow you to do this. You do want a 2D or 3D view where you can scroll through these in the different reconstructions and see where the deformations are actually happening. And this is really important because this is not just about doing a deformation and moving on by doing a dose calculation. This is about assessing whether or not what's happened in that deformation is useful or meaningful. And so a physician, for example, might want to take a look at this and say, okay, that makes sense, the bladder's filling or not filled. In a lung, you may want to see where the tumor is going from data set to data set. So it's really important to look at the deformation and get something from both a physical and medical perspective to better understand whether or not the deformation was good. Here is a close-up view where I can take a look at each one of these voxels, and I could say, okay, show me a vector that shows the extent of motion of each one of these voxels and the direction in which this is going. The little guy here is on his head, so I rotated this around, and I'm showing that it was basically going in an inferior direction and slightly anterior, and the physician can say, okay, does this make sense or not? This is a little video, hopefully again shows okay, where I can take a look and slide between the two data sets, and you can see the rotation of the hips. You can see how I guess that's the bladder there, is changing. And this really helps, again, the physician and the dosimetrist understand what happened between the two data sets, and I could choose any of the ROIs, obviously, to show up there. This is another great view, excuse me, of where I show the ROIs before and after the deformation, or rather between the two data sets, forgive me. So, this would be what happened at the time of simulation. I could, of course, change whether or not the grid or solid is for which view, but I can take a look and overlay the structures to find out what happened between the two data sets. It's also important to have a quantitative view of things, and now this obviously is going to take multiple fractions. Here in the upper left, if we just take a quick look, so this is the first 12 fractions, and then here's the volume of the structure, in this case the bladder, okay? And you can see that the volume started up high and then dropped off, right? So we know what happened. The patient had a lot of urine in the bladder to start for the simulation, and then they didn't realize, or they weren't well educated, and this sort of happened with the bladder, which of course has a large impact on dose and everything else that's going on. So here you see for the prostate first 12 the dose per fraction, and you can see here that that dose is climbing based on the position of the bladder. Okay, very important to be able to extract that information and do whatever you want. So while we're on the topic of a quantitative analysis, and I'm not going to spend a lot of time here, but you can get all kinds of good statistics. Again, people say, how do I know everything is correct and that the deformation made sense? You could do things like planned versus delivered for the bladder. You can take a look at the doses. You could take a look at the volumes. Here we can take a look at the structures. We can look at the centroid of these volumes and look at their rotations and translations along with the volume. That's very important. And the other thing that you could do is for points of interest, you can see here again what is the displacement of various points. If you use points, their difference, distance, all that other information that may be useful. And it's not just about that, it's also about dice similarity, which is also available in the GUI, but you could use Python scripting in our case. Other vendors have different APIs, but you can extract information from the results and then apply it a certain way. You can generate reports, you can send it to Excel or MATLAB, whatever it is that you want, for much more careful analysis. Target registration error in this case, along with other information such as Jacobians, image similarities, ROI overlap measures. Obviously, where there's math, Python, and a couple of physicists, you've got a party. And this is just some good stuff that you can output and make part of your reports to demonstrate what's going on. From a practical perspective and an everyday perspective, of course, you can look at DVHs and comparisons of two different data sets and doses that have been calculated. I'm not going to spend too much time on this, but this is a great tool that other vendors have started to come out with. This we call clinical goals. This is not your objectives, but rather your protocol, or what your physicians have defined as the rules, or what they want you to meet as the dosimetrist. And then you can get these red lights and green lights that show you whether or not you've met a certain set of rules. Now, of course, you can change objectives and constraints in the plan to try and achieve those, but this is the medical sort of analysis on whether or not you've met their goals. You also want to be able to see dose difference maps between data sets. So let's say it's a planning data set and you want to see what would happen compared to my original plan. You can get dose difference maps, and of course this is related to the DVHs that I saw in the first place. All right, this is a really important slide, and this is a very difficult thing to explain because there's a huge amount of information that's involved. But you do want to be able to do dose accumulations over multiple fractions on the left-hand side. And what we're seeing here is that this is the intended dose for 10 fractions on my planning CT. Over here, here's what I actually delivered, and that is based on CBCTs where I've calculated dose. I've taken that warp dose and I've accumulated it on the original planning CT, so it's both the same CT, but now this is, I'm saying, the system is telling us this is what you delivered. You get the DVHs that show you what the problem is, in this case with the bladder, and you get the problems that you see in the clinical goals of what you wanted to achieve. So suffice it to say that it's tough to make a good display that shows all the different things that have gone into your analysis. Okay, dose handling. I won't spend too much time here. Here, you want to be able to compute dose on any data set. This is when I have registration, let's say rigid. I can simply tell the system, take the plan, calculate it on that other data set. Could be multiple phases, could be diagnostic, could be anything. Here, I want to be able to deform the dose. So take a reference plan, use a deformation, and map that dose to the next data set, whether it's a phase or whether it's another diagnostic. Okay, you want the ability to do that. Another thing that some people forget about is the ability to sum doses. So, you know, I may have different numbers of fractions in different conditions, and I do want to be able to sum those in a free-form sort of way. So say, okay, I gave 5 fractions of this, 7 fractions of that, whatever it is, and then you can add those all up and you get a good final plan that can go into the chart. I also, in this case, this just shows some CBCTs and CTs on the head and neck. After I import those, or during the course of the patient's treatment, I want to be able to import these data sets and select which data set I'm going to plan on. Very important that you have some flexibility there, as I mentioned before. Just quick notes on CBCT. CBCT obviously is a different density mapping, and the way that we do it is we create these CT density tables on the fly, and what happens is the system tries to auto-find regions based on adipose tissue, muscle, bone, etc., and it creates a stepwise CT density table, which you can, of course, manipulate. I think over time these will change a little bit. Maybe we'll use deformable registration to map densities. Okay, this is a really interesting case that we got during APM, during the Adaptathon, and this actually shows a case where the patient, here's the patient's original plan, and then what we also did was we computed that same plan on the CBCT, and you don't really have to be a dosimetrist to see the difference in the left parotid there. You can see that the dose coverage is different, and that's of course because the patient lost weight, and I have another example of this. The reason I show this is because this is if I map the dose to the CBCT. So what I've done is a deformable registration between the CT and the CBCT, and I said, well, what if I just map the dose from the original over to the CBCT? And you can really see that it's really quite simply wrong, that the dose to the parotid is much, much lower when I map it as opposed to truly calculated with the different physics that's involved in the patient that's lost weight. So this is, you know, I don't want to say that other products that can calculate dose are useless. They're not. But you have to apply logic to how you're going to use those tools, especially when it comes to assessing dose in CBCT. Very quick slide just showing that the other issue with CBCT is that you may not have the right field of view. And so you want the treatment planning system or whatever the analysis system is to be able to handle missing tissue through deformable registration usually to create this tissue where it was missing, and then also to be able to calculate dose considering those areas. All right, so how do you do adaptive therapy? Well, if I do an analysis and I find out that the dose isn't good and I'm not happy, then I tell the system I want to start at a certain fraction, and I say how many fractions are left, and I could do things like change the LNAC or change the prescription, dose, etc. And then what the system should do or can do is move the plan forward to the new data set and create objectives to try and achieve what you started off with. Okay, so that way you don't have to really create a brand new plan. For example, you don't have to put new beams on the new data set, etc. And one really interesting point here is you don't have to include background dose. Obviously you want to for most of the items here, but notice here that for the PTV, I've said do not include the dose. Okay. Now the reason that I did that is because if the target was hot at the beginning part of the first, say, 20 fractions, I don't want the system to go cold on the PTV because it's perfectly okay for it to be hot. So maybe I move forward and I just say that I want to give a uniform dose of whatever the prescription is. Okay, so you want some flexibility on how you assign objectives to the structures in your adapted plan. Okay, now the one quick comment is that there's different ways to do it. I could certainly just take the new data set and blindly create a new plan and say, okay, this is the plan I want. And we did this experiment. This plan was done by someone else. And what we did was we took the initial plan, we took their manually adapted plan, and then we also did an automated adapted plan. And then we took a look at the differences, and what we found is generally that the adapted plans which took the previous dose into account were better. This is a dose difference map showing that it was a bit hotter on the cord in certain areas within the structures. Probably it's okay for here, but you don't want dose to be warmer in the mandible or in critical structures. So adapted plans, we feel, are probably going to generally give better results. All right, a couple of use cases. We're in the final few minutes of the presentation here. In this case, we have a head and neck with shrinkage due to weight loss. And again, there is always the choice of doing blind replanning or using, say, the first 10 fractions to use that as background dose for the optimization. Here you can see a rigid registration which sort of demonstrates the difference in location and thickness of the patient based on the fact that they've lost the weight, and you can see, of course, that there is a difference. And then if you calculate the dose, so in this case what we did was we had the dose that was calculated to the patient in the initial planning CT, and then we simply moved the beams over based on the registration, and while it's not completely obvious here, one can expect that the dose is going to be pretty different, and you could physically see the difference in the size of the patient. You probably don't need to know that much about physics to assume that the dose to the parotids are going to be different. On the replan CT, they're obviously hotter. You don't always see differences in the GTVs or PTVs, but you can see them in organs at risk. I mean, obviously that's how these things are designed, and there are big differences due to patient shape. So in this case, what you would do is you would do a plan with the background dose from the 10 fractions, and you end up with a new plan which is going to get you to where you should be, and it does use the background dose and will give you the plan that it is that you want. I have a prostate case that I'll show you a little bit more details on the results from that. So this is the more complicated use case where I have a patient with an approved plan and I have daily images from Cbct. And in this case, it doesn't have to be, I mean, in this case I do have daily, but it doesn't have to be daily. We do have tools within our treatment planning system to say, estimate what it's going to be on days that are missed, or basically I could just do this once a week and take those into account. But the main steps, just so you get a feel for the workflow, is you compute the dose for that Cbct. You have a deformation between the Cbct and the planning CT. I map that dose from the Cbct back to the planning CT, and I accumulate that dose. Then I evaluate and decide, and then I replan if I need to. Okay, so here's that, just as a reminder, here's the window of where we're going to accumulate the dose, and we're going to compare it to what happened, what I planned. We're going to look at clinical goals, we're going to look at DVHs. But it's not just about that. It's about, obviously, accumulated dose, right? We do want to see that the dose is right, but it could be about volume, it could be about location, and I can select, in this case I'm using a Python script here, and I can select ROI volume, ROI dose, ROI position, lots of different metrics here based on a particular ROI, and then I can show a plot which lets us find out, for me, I think one of the important things is shift of XYZ of the centroid of the region of interest. So if I've got a lung tumor, is that tumor moving? Is the volume changing significantly? And this is what you look at with the physician in combination with the DVH, in combination with the dose, to help you decide what's going on in this patient and do you need to replan. So here's an adapted plan. Now, depending on what fraction you were at when you began the correction, this may or may not be great. I mean, you know, it depends on how quickly you decided. So I don't know if you remember one of the slides actually I do have the you know, at the point where we decided that we were going in the wrong direction. So here was the planned and the dashed, and here was what was going on, and an accumulation over, I think, 10 fractions. And then I did an adapted plan, and then these are the results that I get from the DVHs. Now we go back to clinical goals. Here were the clinical goals with the, if I extended out to the total number of fractions and assumed that the errors would be the same, I could see that the estimated total dose to the bladder would be off, and the estimated total dose to the PTV would be off. It would actually be too low on the PTV, too high in the bladder. You do this adapted plan, and what you hope for is this, right, where all of your lights are green, the dose to the bladder is exactly where you wanted it to be, and the PTV is getting 7922, which is only a couple of centigrade off. So you can see that an adapted plan, even in a simple case, could be quite useful. Okay, some final words on quality assurance. There are virtual phantoms that are going to be publicly available and mentioned in TG 132. I'll bring up a slide next from my friends at IMSIM QA, the folks at OSL. But, you know, there's several different phantoms that you can use and sort of do these tests. There's a clinical 4D CT lung that I personally have not used, but we've used them in a couple of studies that have been done internally and I believe published. And then just to comment, especially this was really discussed a lot at APM over the past couple of years, there will be physical phantoms that will become available over time for really good end-to-end testing, right? You want to take a phantom maybe with different volumes that I could put into this phantom and test the system. And you're not just testing the treatment planning system, you're testing the image systems, you're testing CT density tables, you're testing patient repositioning. There's a lot of different things that go into this. So I really think that in addition to virtual phantoms that you'll also have physical phantoms. This is a slide from the folks in IMSIM. They say they're going to have 15 virtual phantoms. This product is available now, and it's editable, transformable, and you use DICOM to do most of the tests. And so this is the kind of thing you would do mostly during commissioning and acceptance. And the workflow is pretty straightforward, I think. I would import DICOM images. I would deform those images in that product. I would export that to the treatment planning system and then run the registration between deformed and original data and then do these comparisons to find out if the systems. Now, if they're similar. Now, of course, that's assuming that you trust what they're doing in this product, but of course it's always good to get a comparison between two independent products. I'm not going to go into this in detail. Mark Kessler from University of Michigan started in 2013, continued in 2014, putting together standard questions that vendors, both treatment planning system vendors and the folks from the standalone products, that they would answer. You know, what are the mathematical models? How many degrees of freedom you have? How do you prove that things aren't being transformed into something unreasonable? What secret sauce do you have? Do you transfer these structures? Do you transfer dose from one scan to another? Things that may be important to you, and what the recommendation is to apply these to RFPs or tenders or your questions and get yourself educated on the kind of questions to ask. And the questions go on and on. All right, future stuff. Last couple of slides. GPU operations, I mentioned that before. Really important to speed up deformation, really needed to enable online work. You don't want this all to be offline at some point in the near distant future. We'll all be doing deformable registration while the patient's on the table. Treatment planning system will calculate the dose, zap it to the R&V system. Certain minor things will be assessed to make sure it's okay to go ahead that day. And then this online adaptive is going to become standard. Of course, there's a dramatic increase in speed, but it depends on the case, depends on the specifications of the hardware that you're using. What other future items come to mind? Automated assessment and protocol-driven adaptation. So dosimetrists should spend their time on the hard stuff, not on the hard steps or work that goes into looking at this. So really, it's great if we're able to look at the results and decide why did I see a big shift in the prostate or in the bladder. That should come out, bubble up to you from automated events that happen in the treatment planning system. Data mining from what's gone before to help you with automatic planning and reporting. For example, you will have to decide at some point when you do an adaptive plan. So what discrepancy needs to occur, whether it's in PTV or OARs, to require a new plan to be done, and what is X? EPID-based online monitoring and retrospective analysis, so combining image data and dose data and everything that goes along with it to have an overall evaluation. For us, better extrapolation of dose accumulation. So this is not simple. You know, if I do 7 fractions, how do I know what the 44 fractions will look like? And the answer to that is that you have to have a better view on the error statistics that go into ROI positioning, patient positioning, tumor movement, organ movement, etc. And how do you incorporate those motion models from that patient into the extrapolation? Biological factor incorporation, everyone's talked about biology for years. Will we use it ever in adaptive treatments? I think so. And incorporation of more functional imaging, whether it's MRI, etc. These are things that, as we go forward, that will all factor into our analysis on a day-to-day basis. And that, my friends, with 4 seconds to spare, is my presentation. Just would like to thank Stina Svensson, who's lead developer for Deformable Registration at RaySearch, Freddie Cardell for his work. When I said I did some of those plans, it was really Freddie that did the plans, not me. Christy Brock, Associate Professor at University of Michigan, and OSL for my use of their images in the presentation. I think, so that's it. So Kara or Spencer, I think, do we want to advise people on the quiz, and should we just sort of slip right into the questions at this point?
Yeah, that'll work. Again, we told everyone at the beginning, the link to the quiz is all over the homepage. What Mark has circled here will take you to the quiz. I've also put some under the general, right there. There's also a link just under the, what is it, general information, I believe. Hold on a sec. Oh, featured news. I added a new link there. So the quizzes will be here all week, that exact same spot where it says webinar quiz will be posted. The webinar quiz is posted now. Go in. You have until September 30th to take it and receive your credit. If you have any questions, feel free to put them in the question box. Freddie and Mark will answer any for RaySearch, and I will feel free to answer any for the webinar or National Medical Dosimetry Day / week. At this point, if you need to go out and do your treatment plans, go ahead. If those that want to stay around for question and answers are welcome to stay and ask.
Freddie, do you want to call out some questions that we may want to use?
Sure. I mean, there aren't a lot of them yet, but there was one question on basically asking on a deformable registration plan, which I'm assuming is an adaptive plan, how is the reimbursement on the build plans? Basically a billing question. They wanted to know if the insurance companies would pay for these plans.
So we've spoken to several consulting organizations. The one that we use the most is Revenue Cycle, who I'm sure many of you know. The conclusion as of at least 6 months ago, I doubt anything dramatic has changed, is that you can charge for additional plans, but you have to have significant documentation that proved why you needed to do that. And so RayStation can help you there. For example, if I show a DVH image, which shows that either the tumor volume or an organ at risk is going to have too much or too little dose, and that an adaptive plan will correct that, along with as much image and plan report information as you can get, then there's a good chance you'll get reimbursed. There is not a separate code at this point in time for adaptive replanning.